I'm pleased to introduce today's speaker, Dr. Pamela Kunz. Dr. Kunz is an associate professor of medicine in the Department of Medicine and Division of Oncology at Yale School of Medicine and director of the Center for Gastrointestinal Cancers at Yale Cancer Center. She also serves as the chief of GI Medical Oncology and co-leader of the Neuroendocrine tumor program. Dr. Kunz received her medical degree from Dartmouth before receiving her postgraduate training at Stanford. She then served as faculty at Stanford for 10 years, where she was the founding director of the Neuroendocrine tumor program before she moved to Yale in 2020. Dr. Pamela Kunz currently holds a number of key leadership positions in the NET cancer community, including the chair of the Neuroendocrine Tumor Task Force of the NCI and member of the LACNETS Board of Directors. She serves on the NET Working Group of the Eastern Cooperative Oncology Group, or ECOG for short, and she has been a longtime member of the NCCN Neuroendocrine Tumor Panel. Dr. Pamela Kunz is a leader in clinical trials and research. She's working to expand research programs in order to bring new treatments, biomarkers, and epidemiological insights to the field of NETs. She's been involved with the design, development, and conduct of numerous phase 1, 2, and 3 clinical trials in the field. And she serves as a co-chair for the NCI-sponsored NET Clinical Trials Planning Meeting, Treatment in the Era of PRRT, which she will discuss in her presentation. I also want to highlight that Dr. Kunz was recognized as the 2021 Women Oncologist of the Year by Women Leaders in Oncology for her commitment for advancing diversity, equity, and inclusion, or DEI, through her research, community leadership, and talks. We are deeply grateful and supportive of her commitment to diversity, equity, and inclusion, which is also near and dear to our hearts. We are pleased to call Dr. Kunz a friend. She has joined us in the past for several pre-pandemic in-person annual conferences, as well as last year's 2021 virtual conference. And on a personal note, Dr. Kunz was one of the very first NET experts I met after my husband was first diagnosed with NET back in 2015. And I'm grateful for her expertise, her dedication to the NET cancer community, and her kindness towards me. We are very pleased to have Dr. Pamela Kunz join us to discuss what's new with NETs. And now let's welcome Dr. Pamela Kunz.
Hello, everyone. My name is Pamela Kunz, and I'm an associate professor of medicine at Yale School of Medicine and the director of the Center for GI Cancers and co-leader of the Neuroendocrine Tumor program at Yale. It is my pleasure to speak to you today on what's new with NETs and what's on the horizon. These are my disclosures. So we will do a very brief review of NETs and clinical trial definitions just to make sure everyone's on the same page. I know we have a mix of patients in the audience, some of whom have been newly diagnosed and some of whom have been living with NETs for a while. We'll talk about current NET treatment options also very briefly, and really the focus of today's talk is on what's new. And I've put that into 4 main categories: the NCI NET Clinical Trials Planning Meeting, targeted alpha therapy, brief update on surifatinib, and then some data hot off the press from GI ASCO. So I really like starting with this slide, and some of you may have seen this on recent advances. I think it really just shows how far we've come. In the 1980s, we really only had 2 therapies available for neuroendocrine tumors: streptozocin, which is a chemotherapy, and octreotide. And it was really not for another 30 years. We had to then wait until this explosion of NET research, both in terms of imaging, those are all on the top of the line, and then all of our therapies down below. I'm not going to go into all of these today, but I think that this is a really nice visual, and I think it gives us a lot of hope that we are still on the same trajectory. So I know some of you have heard NETs 101 by me and other physicians. I have put it all on a single slide, so it definitely oversimplifies it. But I want to just be sure we all are coming to this with an understanding about some of the basics of NETs. So it's important to know primary site if we can. Neuroendocrine tumors can originate in almost any part of the body, most commonly the GI tract, followed by lungs, followed by other sites. In terms of epidemiology, NETs are rare by incidence. That's the number diagnosed per year. However, they are more common by prevalence. That's the number of patients alive at any given time. In terms of hormones, neuroendocrine tumors get part of their name, endocrine, because they can secrete hormones. And symptoms plus a measurable hormone in either the urine or the blood means that it's a functional neuroendocrine tumor. No symptoms, no hormone secretion or symptoms not from hormones means that it is non-functional. The stage is extent of disease, meaning where is the cancer in your body. That's usually determined by imaging, and there is a staging system, usually stages 1 through 4. We also talk about grade and degree of differentiation, and this usually helps predict the pace of growth or refers to how fast dividing the cells are. Grade 1 is based on, all of these grades are based on looking at the Ki-67 and mitotic index. I've just listed the Ki-67 ranges here. So a grade 1 is a Ki-67 1 to 2, grade 2 is 3 to 20, and grade 3 is greater than a 20. Grades 1 and 2 are usually lumped together in terms of how we treat patients. And then the somatostatin receptor status is something that has become increasingly important over the last few years because we now have therapies that target the somatostatin receptor, including PRRT. The somatostatin receptors are present on over 90% of cells in grade 1 and 2 neuroendocrine tumors. So this is just for starters, and I certainly can answer more questions on this at the end. I'd like to just also briefly mention the clinical trial pathway. I have spoken about this before, but I think this is also a really nice place to start because we will be talking about clinical trials later in the talk. So clinical trials first originate usually in the lab, where there is basic research done, drug discovery, and preclinical research. We then move into phase 1, 2, and 3 clinical trials. So if a drug is deemed promising in a preclinical study, it goes into a phase 1 study. That's to determine the safety. If it's safe, it then goes into a phase 2 study to determine is it preliminarily effective. That's usually, but not always, a single-arm study, so all patients get that medicine. Sometimes phase 2 studies can also be randomized. If it's deemed preliminarily effective, it then moves into a phase 3 study. That's usually comparing the new drug to an existing standard of care drug or to a placebo. And then down below in this figure, you can see the number of patients that are involved in each of these phases. So phase 1 has maybe tens of patients, phase 2 hundreds, and phase 3 hundreds to thousands. It then goes to the FDA for review, and then afterwards there are phase 4 studies, which are post-marketing safety studies to get additional safety data. This entire process can take 10 plus years, which is, I agree with you, way too long, and we're trying to figure out ways to be more nimble. There are a number of ways that these clinical trials can get funded or where ideas are thought up for clinical trials. They can be through the federal government, through pharmaceutical companies, and through individual investigators like myself at our home institutions. The FDA review process is something that I have often found very opaque, and I think it's worth just briefly mentioning. I am newly a member of the FDA Oncology Drug Advisory Committee, so I have personally learned quite a bit over the course of the last year. So when a phase 3 trial is completed, a new drug application is submitted to the FDA, and this includes data from that entire process that we just went over. And they also propose labeling and safety updates and patent information, et cetera. The FDA checks for completeness and has 6 to 10 months to make a decision. This is called the PDUFA date, Prescription Drug Use Free Act. And if it's approved, the FDA assists with refining these indications. And then there's post-marketing safety monitoring that continues. So this Oncology Drug Advisory Committee that I am a part of, I wanted to just mention this, and I'm happy to answer questions about this also. This committee is responsible for reviewing and evaluating data about the safety and effectiveness of all cancer drugs, both those that are marketed and those that are investigational. There are 13 voting members on this committee. They include many oncology specialties, both in pediatrics and adults, and include biostatistics and consumer interests. And there is one non-voting industry member. These are actually, when these committee meetings occur, they are actually broadcast on the web and allow public participation, including from patients. And so I wanted to just flag that to this patient community. If there happens to be a drug advisory committee in which a neuroendocrine drug is reviewed, that might be of interest to this committee. And so I put in the link, the webcast for the 2022 meetings. So current NET treatment options, I'm not going to go into lots of detail, but I wanted to highlight the NCCN guidelines. There is a patient version of this, and I think it's actually a really great way to look at algorithms for how patients with NETs are recommended to be treated. And for pancreatic NETs, we have a number of therapies, including everolimus, sunitinib, Captem, and ludotatate. And for small bowel NET, we have everolimus and ludotatate, and then of course there are clinical trials. For lung NETs, we have some similar options, so octreotide and lanreotide, everolimus and Captem, that's for the low grade or typical carcinoids. And for the intermediate grade or atypical carcinoids, we sometimes will use radiation therapy and platinum etoposide, but we will also sometimes use Captem, octreotide, lanreotide, or everolimus. So what I really would like to focus on for the remaining part is what's new. I know that's what I was asked to talk about today. So we are going to break this down into 4 categories. The Neuroendocrine Clinical Trials Planning Meeting, Targeted Alpha Therapy, Surifatinib, and data from GI-ASCO. So I wanted to just define, this is one mechanism that we can do clinical trials, and I wanted to just break this down a little bit. So the National Clinical Trials Network is a network of 5 US groups and 1 Canadian group. Of the 5 US groups, there are 4 that focus on adult treatments: SWOG, Alliance, NRG, and ECOG-ACRIN. These are all funded and sponsored by the National Cancer Institute and the NIH, so they are federally funded. I am part of 2 of them from ECOG-ACRIN and SWOG. And basically, most academic institutions belong to one of these. This really allows us to work together as institutions to help develop and conduct clinical trials. I would say it's especially valuable for rare cancers like neuroendocrine tumors, where we need to really collaborate in order to get enough patients on clinical trials. So I am currently the chair of the NCI NET Clinical Trials Task Force. So this allows me the opportunity to really oversee all of the NCI-sponsored clinical trials through this National Clinical Trial Network. In the course of doing that, we had the opportunity to lead a clinical trial planning meeting. I did that with Drs. Tom Hope, he is a nuclear medicine physician at UCSF, and Dr. Simran Singh, who is a medical oncologist in Canada. The 3 of us together hosted this clinical trial planning meeting, and we entitled it Treatment in the Era of PRRT. We had it just under a year ago. And we felt that because ludotatate or Lutathera was such an important treatment in the last few years, that we wanted to think about how should we be thinking about future treatment in the context of this new PRRT therapy? Should we be thinking about ways to improve it, ways to lower side effects? And so the objectives are listed here. We wanted to enhance efficacy and evaluate treatment for PRRT refractory disease. We wanted to examine dosimetry and timing. Dr. Hope helped lead that subgroup and develop standard criteria for clinical trial design and correlatives, and Dr. Singh led that. This required about 1.5 years of planning. It actually was also originally planned for March of 2020, and we all know what happened then, so it was delayed a year. And we did lots of pre-meeting planning, and we had a 1.5-day meeting where we did some of the hard work. We now, over the course of the last year, have worked on developing, kind of in these last few bullets, a manuscript of the meeting recommendations. There is actually an executive summary already online, and I'm happy to make that available afterwards if there's interest in looking at that. It's public. And then in terms of the clinical trials, that's actually the main goal of this meeting, is to develop clinical trials. And the first is already in development. It's a PRRT retreatment. It's called NET Retreat. It's being led by doctors Aman Chauhan and Simran Singh. And this is to look at are 2 additional cycles of ludotatate safe and effective after someone has already had a standard course of treatment. We have 4 working groups looking at other elements in hopes of developing future clinical trials around PRT plus DNA damage repair inhibitors, PRT plus immunotherapy, PRT plus liver-directed therapy, and also dosimetry. So this is a table of 5 current NCTN clinical trials, actually many of which have just opened in the last year. It's very exciting. So the first one many of you know about already because it's been open since 2020. So it's called the CABINET clinical trial. And I'll just walk you through the table. So the first column has the kind of number associated with the study. That NCT number is what the clinicaltrials.gov website has in the way to identify the trial. The design column tells you if it's randomized, that's R, what phase it is. And sometimes if it's randomized, like with the CABINET study, it's randomized 2-to-1, meaning that there are sort of a 2 out of 3 chance of getting the cabozantinib versus a 1 out of 3 chance of getting the placebo. The next column shows the indication. So the primary site, the grade. The next column shows the drugs that are involved, then the principal investigator, and then the N is the sample size. So how many patients have been enrolled so far out of the total planned? So the CABINET study being led by Dr. Jennifer Chan at Dana-Farber, is about halfway accrued, which is really exciting. So cabozantinib is a tyrosine kinase inhibitor. It's a pill, and we are examining that versus placebo. The next study is a randomized phase 2 study in paraganglioma and pheochromocytoma. So another kind of rare subset of NETs. This is examining temozolomide versus temozolomide plus olaparib. So this is a PARP inhibitor, and it's felt that this may make temozolomide more effective. And this is being done by doctors Perez and Del Rivero, and that has just started. The next study is a randomized phase 2 study in advanced bronchial NETs who are somatostatin receptor positive. So another really exciting trial because lung NETs, I think, are an area that we all need more prospective clinical trials. And this is looking at ludotatate versus everolimus in lung NETs and being led by Drs. Tom Hope and Dr. Suki Pada. This has just opened and they're just kind of ramping up. The next study also just recently opened. It's a randomized phase 2 study looking at adjuvant or postoperative treatment in pancreatic NETs who are high risk of recurrence. I'm going to go into that one specifically in a little bit more detail, but it's looking at CAPTEM for 4 months versus observation. As many of you may know, unlike many other GI cancers, we currently don't have data that support using treatment after surgery. We usually just recommend observation. So this is an important study that will hopefully help answer that question for pancreatic NETs. And then lastly, we have a study looking at advanced poorly differentiated small cell neuroendocrine carcinomas, so our higher grade tumors, looking at platinum and etoposide plus atezolizumab, which is a form of immunotherapy. And that's being led by Drs. David Zen and Gabby Churian. So hopefully I've shared with you, this is a really broad portfolio that addresses needs of multiple different subsets of NETs. I think it's really exciting that all of these are now open throughout the United States, hopefully at many of your local institutions. So let's talk about targeted alpha therapy. I know that there is a lot of interest in discussing this topic. So I'm going to use a cartoon just to describe how we think about somatostatin receptors in the field of theranostics. So imagine this group of people in my cartoons. We would really like to figure out with an imaging tool, how can we figure out if they have a target that we're interested in? So that target is in green. So I'd like to select out that group of patients with a target. I actually do have an imaging tool that can do that. Those are the gallium-68 DOTA-PETs or copper-64 DOTA-PETs. That will help select out this group of patients in orange with that green target. Well, and wouldn't it be great if I had a treatment that could target that same target? And in fact, we do, and we will talk about some of those. So that's the peptide receptor radionuclide therapy. And using the same target for therapy and diagnostics or imaging equals theranostics. I like to use the lock and key analogy. So the lock is the somatostatin receptor. Tate is the key, so it's like octreotide. There's a linker, and that linker attaches the reporting unit, which for imaging is like the light bulb, and for treatment delivers radiation directly to the somatostatin receptor. So the imaging reporting units or radioisotopes are gallium-68 or copper-64, and for treatment, lutetium-177 is Lutathera, and then we are starting to talk about alpha emitters, so lead-212 is one example of that. I'm not going to focus on imaging today, but just to give you a brief history of the therapy, peptide receptor radionuclide therapy has actually been around since the 1990s, but really wasn't studied until more recently in prospective clinical trials. So in the 1990s, we started looking at PRRT using a radioisotope called indium-111. In fact, some of you may remember that that's actually the radioisotope used for Octreoscan, which has really been completely replaced by DOTA PET scans. In the 2000s, another radioisotope, yttrium-90, was used. And we still use that sometimes for radioembolization for a liver-directed treatment. Some of you may have also heard of that. And then in the 2000s, that's when we started looking at lutetium-177, and that led to the NETTER-1 clinical trial, which I will briefly review. And now in the 2020s, we are looking at targeted alpha therapy with lead-212 and actinium-225, and hopefully we'll see more and more clinical trials. So I'll remind everybody just about this phase 3 clinical trial with ludotatate that was NETTER-1. So this was, hard to believe now, approved 4 years ago, I think. It was in 2018. So this was a large international randomized clinical trial of over 200 patients with mid-gut neuroendocrine tumors. 1-to-1, actually that's an error on there, to receive 4 administrations of ludotatate every 8 weeks or octreotide LAR at high dose, 60 milligrams. I'm going to briefly remind everybody how to read a survival curve because we will be talking about a few of these in the subsequent slides. So this is a progression-free survival curve. The horizontal axis is months since randomization. The vertical axis or y-axis is the progression-free survival. So that's the percent of patients who have not progressed. And progression-free survival is the preferred endpoint for NET clinical trials. The dashed line is the median progression-free survival. And so here are the results. This is just an example using the NETTER-1 data. So the separation of the curves is really good. So the green line is the experimental line. So that's the ludotatate treatment. At the time this was published, it had not reached median. Yet the octreotide arm had a median progression-free survival of 8.4 months. So the separation means that there's a difference between those two lines, and that's important when you're doing clinical trials. And in fact, we now know that the median progression-free survival, which has been updated, is about 2.5 years. The hazard ratio indicates a kind of reduction in risk. So there was a 79%, so the opposite of that hazard ratio, 79% reduction in the risk of progression by patients, for patients getting ludotatate. So this is just, I'm putting them side by side, the progression-free survival and overall survival curves for this study. So this was a very successful study. And ludotatate was FDA approved in January of 2018. So very exciting. So briefly before we go into the alpha therapy, I want to just say that somatostatin receptors are really a great target. And we now know that because of Lutathera, but there are other types of medicines or drugs that are also targeting the somatostatin receptor. I'm just have listed that I'm not going to go into lots of detail, but I think this is a really interesting area of research. So Lu-177 saderatide is a somatostatin receptor antagonist, a form of PRRT. The ludotatide is an agonist. So they work differently to activate the receptor. And there was a small phase 1 clinical trial that looked at this. PEN-221 is a peptide drug conjugate. So it basically takes a medicine like octreotide and links it to a chemotherapy. So it helps drag that chemotherapy directly to the somatostatin receptor. Tidutamab is a somatostatin receptor that's linked with CD3. It's a bispecific antibody, and this is actually a form of immunotherapy. This has just been reported in a phase 1 trial. And then lastly is lead-212 dotamtate, which is the alpha emitter, and we will go into this in a little bit more detail. So targeted alpha therapy. So it works in the same way as this lock and key. So it targets the somatostatin receptor. Tate is the key. So that's like the peptide that links the somatostatin receptor. And then the DOTAM attaches that key to the reporting unit. And we're going to talk about lead-212. So lead-212 dotamtate is the first lead-212 labeled octreotide analog to treat somatostatin receptor expressing NETs. So it consists of those 3 linked components, which I have up there in the cartoon, the Tate, the DOTAM, and the lead-212. Well, we know that it provides a higher linear energy transfer in a shorter path length. And the theory is that the higher energy increases cancer cell damage, and the shorter path length leads to fewer side effects. So that's the hypothesis. So Dr. Delpasand at Excel Diagnostics in Texas just published his preliminary experience with the phase 1 trial in January of 2022. So it literally just came out a few weeks ago. So in this phase 1 trial, so I'll remind you, phase 1 is really, the purpose is to look at safety. And we get a hint at efficacy, but I won't go over what that is. So he enrolled so far 20 patients with advanced NETs. 10 patients received slow dose escalation. So the purpose is to test slowly increasing doses to look at safety, and then determine what that recommended dose is for the next phase, for phase 2. And then 10 patients received that recommended phase 2 dose. The side effects were nausea, fatigue, and hair loss. And the response rate, or the shrinkage rate, of those 10 patients treated at the highest dose was 80%. So that's actually very promising. So 1 patient had a complete response. 7 patients had a partial response. And in clinical trial jargon, partial response means 30% shrinkage or more of the spots that we're measuring. And then 2 patients had stable disease. So in this figure on the right, you can see a patient. The figure on the kind of leftmost portion of the screen is the gallium-68 DOTA PET scan before treatment. The dark spots represent tumor spots. And then patients received 4 treatments. And then the picture on the right is that same patient. This is a 47-year-old man with a metastatic bronchial carcinoid, and that patient appears to have had a near complete response following that treatment. So I want to just be cautious. This does not necessarily mean cure. It is that radiographically, those spots appear to have disappeared. So I think I want to help you interpret this data. So a reminder, this is a phase 1 study. The main goal is to assess dose and safety. This is also a preliminary report. So we haven't seen all of the data yet. And this response data is only shown in 10 patients. And I'll remind you that most of the phase 2 and 3 studies, which we hope to see following up to this, are hundreds of patients. And so this is very early data. So the NET expert community is cautiously optimistic about this targeted alpha therapy, but I think that we really need more data and larger studies before this is put into practice. So this is, just to remind everybody, not available outside of clinical trials, but we are eager to see more clinical trials, and I anticipate we will see more this year done by other companies. I wanted to give you a brief update on surufatinib. I think I talked to this group last year about this drug. I'll just remind you that we had 2 positive studies in 2020. They were conducted in China. They are called the LACNET studies. And this is with a drug called surufatinib. And it targets, on the right here, you can see the 5 kind of targets: vascular endothelial growth factor receptor, a fibroblast growth factor receptor, and a colony stimulating factor receptor. And we'll talk about what those mean. One of the studies was done in pancreatic nets, that's SANET-P, and the other was done in extrapancreatic nets, so basically everything other than pancreas. Both of these were positive studies. They prolonged progression-free survival. You can see from what you learned before, those curves are separated. The side effects are hypertension, high blood pressure, protein in the urine, elevated triglycerides, and diarrhea. So this medication was approved by China's National Medical Products Administration, so that's like our FDA, back in 2020. Given that these studies were only conducted in China, they cannot immediately submit to the United States FDA. So a phase 1/2 study was conducted in the United States of 32 patients. There were no new safety signals. The response rates looked very similar. The progression-free survival was not yet available. This was conducted by Dr. Desari and colleagues. And so now, with this data, they have submitted to the FDA a new drug application. If you remember when we talked about that FDA process, the PDUFA date, which is basically the date at which the FDA has to make a decision, is actually coming up. It's in April. So I hope that we learn more then. And then why does surufatinib yield higher response rates? I didn't focus on this, but compared to some of our other available oral agents, surufatinib is another pill, so like Afinitor and Sutent, those typically have very low response rates, under 5%. Surufatinib in pancreatic nets has a response rate close to 20%, so that's that shrinkage rate. And the thought is this is actually a combined angioimmune mechanism. That means it attacks the blood vessels and it stimulates the immune system, I should say. And so I think that's what's really interesting. This drug has a slightly different mechanism of action than some of the other IBs. So those drugs names that end in IB are tyrosine kinase inhibitors. I'll finish up with just talking about our data from GI ASCO that we just finished last week. And I had asked the LACNETS organizers if I could give this talk after GI ASCO, so I had a few more things to talk about. So the first abstract I want to highlight is actually a really important prospective phase 3 clinical trial comparing etoposide and cisplatin versus irinotecan and cisplatin in gastroenteropancreatic neuroendocrine carcinomas. So this is the higher grade neuroendocrine carcinomas. Typically, platinum and etoposide has been our standard for many years. That's based on borrowed data, actually, from the small cell lung cancer community. So in this abstract, they compared these 2 medications and actually found that there was no difference. It is really important prospective data. I think you may all think, well, why is that so exciting? And I think because it actually gives us another, we can also use irinotecan and cisplatin. We can still use our old gold standard etoposide and cisplatin, but we really never had prospective clinical trial data in NECs. So that's why this is also important. There was a small study that came out of Memorial Sloan Kettering looking at checkpoint inhibitors in neuroendocrine neoplasms. So that's a form of immunotherapy. And in their study, they looked at 57 patients with both well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas in a real-world setting. And in fact, the takeaway, and I'll go in the details in a moment, is that there's very limited or low activity of immune checkpoint inhibitors in neuroendocrine tumors. I think this is important. It reinforces data that we already knew. I know that the DART clinical trial, which came out about a year or so ago, that was with ipilimumab and nivolumab, kind of got a lot of press, but it was very small numbers, and that was a combination of two immunotherapies. I think what we're seeing from this is that we need to be really selective in which patients we may consider immunotherapy for. Patients with neuroendocrine carcinomas tended to have a higher response rate, but even then it was still quite low. So I'll just go through the data a little bit. The well-differentiated neuroendocrine tumors had a 6% partial response rate, so that's quite low. That's the patients that actually have objective shrinkage. And for the poorly differentiated neuroendocrine carcinomas, there was about a 15% partial response rate, so a little bit higher. So I think the takeaway from this is that indeed there is limited activity for these checkpoint inhibitors. That's a specific class of therapies. I think that we're looking at ways to make these more effective by combining them with other treatments, perhaps even with things like PRRT. So stay tuned. I think the story is not over with immunotherapy and neuroendocrine neoplasms. There was another interesting study looking at young onset patients with pancreatic neuroendocrine tumors. I think that the idea of looking at all cancer patients who have early onset has become very important recently, particularly given that we've seen early onset colorectal cancer be more prevalent. And so this was a single center study, also done at Memorial Sloan Kettering. They looked at 366 patients with pancreatic NETs. They defined young onset as less than 50. So of that group of 366, 23% had young onset and 77% had later onset. And what they found is that in these kind of sort of infographics, it was not associated with a personal history of cancer for patients with young onset pancreatic NETs and not associated with a family history of cancer. The pathologic characteristics, so what we look at under the microscope, and the long-term outcomes did not differ between young onset and later onset. This study is out from our colleagues at Moffitt Cancer Center. So Dr. Strasberg's team and his colleague, Dr. Altuba, presented this. This was a retrospective study looking at the risk of MDS. So that means myelodysplastic syndrome. It's a form of kind of an early form of leukemia. And I think that we have had theoretical concerns about the use particularly of ludotatate and risk of MDS. That risk is felt to be about 3%. But temozolomide, which is in a class of medicines called alkylating agents, also carries a risk of myelodysplastic syndrome and leukemia. So this was a study to look at the risk of MDS and leukemia after patients received both of these treatments. And so they looked at their patients, found 462 patients who had received CAPTEM, and then of those, 49 had also received PRRT. And they found that 4 of those patients, so 8%, who had received both, developed MDS or AML. And this is actually higher than associated with PRRT alone. None of the patients who received CAPTEM without PRRT developed MDS or AML. So I think this takeaway is that this cumulative risk really does need to be considered when patients are getting both. I think that the idea of survivorship in patients with a more chronic cancer like the grade 1 and 2 neuroendocrine tumors is really important as we think about these side effects. This is a study that I'd mentioned earlier. This is one of our newest National Clinical Trial Network studies. It's a phase 2 adjuvant study of CAPTEM versus observation in high-risk pancreatic NETs by Dr. Heloisa Suarez and team. So in this study, it is a 2-to-1 randomization. So patients who enroll on this get a 2 out of 3 chance of receiving CAPTEM for 4 months versus a 1 out of 3 chance of getting observation. High risk is defined by this scoring system on the right. It's called the Zaidi score. And patients have to have either had a prior symptomatic tumor, as defined by a gastrointestinal bleed, jaundice, GI obstruction, pain from the primary tumor or pancreatitis, a primary pancreatic tumor greater than 2 centimeters. They get a 1 point for a Ki-67 of 3 to 20, 1 point for lymph node positivity, and 6 points if the Ki-67 falls into that grade 3 range. And so they are eligible if they have a score of 3 or more. So again, an important study really will help define the role of postoperative treatment in patients with pancreatic NETs. So take-home points from today. I hope you have seen and are really hopeful about the fact that we've made many advances in the last 10 years in terms of both treatment and imaging. Clinical trials are really critical to make progress in NET treatment, and I hope you've seen really just in the last year how many advances we have seen. And a targeted alpha therapy does hold a great deal of promise, but it requires more data before being ready for standard of care treatment. And please stay tuned for more NET trials this year. So it is my pleasure to speak to you today. I thank the LACNETS organizers for the invitation, and I look forward to our Q&A. Thank you so much.
Thank you for that very informational presentation. And we had participants comment about how much they love you and how much they appreciate the slides.
Thank you. I'm excited to be here.
Well, let's get started. We have a lot of questions that have come in, and so we'll just go right through them if you don't mind. One of
Sure.
the first questions that came up is curious to hear how other countries compare with their clinical regulatory pathways. Are they faster or slower than our process with the FDA?
That's a great question. I am not intimately familiar with the regulatory process in some of the other countries. Um, I can say maybe just a few brief comments based on what I know about our own FDA, which is that I think we have high standards and really want to be sure that the research is done in a way that has high scientific integrity, that the clinical trials are done in a way that allows us to learn about diverse patients. So, for example, if it's a multinational randomized trial, it's actually required, if it's going to be eventually approved by the FDA in the United States, that it be done in multiple different countries and include different races. So I would say that our FDA probably has a higher bar, but I think that's actually good. And it's really for patient safety and to ensure efficacy of treatments.
Great, thank you. That's very helpful. So there's several questions that came up about somatostatin analogs. Very popular topic since many people are on it, as you noted. So one question is, how long after starting the somatostatin analog, either lanreotide or octreotide, would one see its effects on liver mets? In particular, this person's asking about shrinkage.
That's a great question. So I'll answer this maybe in a little bit of a long way. So we know that somatostatin analogs, in fact, they were first approved on the basis of helping patients with carcinoid syndrome. So those are patients that have elevated serotonin or urine 5-HIA and have flushing and diarrhea. So we knew that this was an anti-hormone treatment to begin with, and it helped lower those hormone levels. It was really only after that we learned that it also had an anti-cancer benefit. It slows the treatment or slows the progression of neuroendocrine tumors. It does not generally shrink them. So at best, we hope that it yields stability. And we generally use octreotide and lanreotide interchangeably. There are different clinical trials that have shown the anti-cancer benefits of octreotide and lanreotide. So I hope that answers the question.
Yeah, and actually, this might be a good segue to this next question, which you've already touched on. If you could please describe how the somatostatin analogs work to eliminate NET tumors.
Sure. So somatostatin analogs are an inhibitory hormone. So they're not a chemotherapy. I really describe them as a hormone therapy, not that affects male or female hormones, but affects hormones that are involved with the development of neuroendocrine tumors. And a good way to remember this is that we actually use somatostatin analogs for reasons outside of cancer to really inhibit things. So we use somatostatin analogs in the case of upper gastrointestinal bleeding because it can kind of decrease blood supply to the stomach and the stomach lining. So that's for people who have esophageal varices. We'll sometimes do that. Those are kind of enlarged plump blood vessels. And we know that it lowers hormone levels. as a side effect of treatment of somatostatin analogs, we know that it can inhibit or decrease secretion of pancreatic digestive enzymes. That's actually why some people who are on long-term somatostatin analogs get pancreatic enzyme deficiency and need to be put on creon or pancrease or a supplemental enzyme. And so similarly, it inhibits hormones that neuroendocrine tumor growth. It's not going to shrink cancers, but it does help stabilize, prevent new spots, prevent existing spots from going. And in many cases, that can be for months to years.
That's very helpful and very clear. Thank you for that. So another person's asking, what is the latest research regarding the utilization or elimination of somatostatin analogs when it appears to not be effective in halting tumor growth?
So I'd say this is a kind of general principle for how we treat cancers generally. So usually we will start with one treatment. And in this case, this question is asking about somatostatin analogs. And that's actually often one of our first go-tos for treating patients with metastatic grade 1 or 2 NETs. And we use a treatment as long as it is working, meaning that as long as it's controlling the growth of the cancer and as long as patients are tolerating it okay. And if at some point we see evidence on scans that the treatment or that the tumors are either growing or there are new spots, we generally will stop a given treatment and move to something else. So for somatostatin analogs, and like if someone happens to be on everolimus or Cape-Tem, we would use that same principle. Cancer cells can get smart and develop mutations and become resistant to a given treatment. Now, I will say the one caveat to that is for patients with functional NETs, if they are taking a somatostatin analog because they secrete serotonin or we're trying to use that somatostatin analog to suppress a hormone, those patients will remain on somatostatin analogs lifelong. And if they have evidence of tumor progression, we will add something to that.
Thank you for that. And another question that's related to stopping the somatostatin analogs, is it okay to take a break from sandostatin LAR or lanreotide for a few months if deemed stable post-PRRT? And what's this? I know you already addressed the second part. What's the statistics on sandostatin for limiting tumor growth?
So so happy to try to address this. So and I might weave in just a comment about whether or not you need SSAs while you're on PRRT, because I think that's actually a controversial topic. So the NETTER-1 clinical trial had required that patients get octreotide every 8 weeks, along with the Lutathera. In practice, most of us, for patients with functional, so secreting hormones with functional NETs, will continue octreotide or lanreotide. And again, they receive that lifelong, so before, during, and after the PRRT. For patients with non-functional NETs, in whom if they have evidence of tumor progression and that's what triggers using the PRRT, I usually stop the sandostatin or the somatostatin analog and don't go back to it. If the only reason I was using it was for tumor control and it's no longer controlling the tumor, I don't continue it. There is some controversy with that, but I would say that the majority of NET experts will not continue somatostatin analogs for non-functional NETs if they're going to change to another treatment.
Okay, that's very helpful. And again, with starting or stopping somatostatin analogs, what if someone's NED, so no evidence of disease, but following surgery, following cytoreduction? So they were on lanreotide for 3 years before surgery. It controlled the metastasis. Should they go back or stay on the lanreotide to lengthen their PFS, so progression-free survival? Thank you.
That is an excellent question, and we don't really have any evidence to guide that answer. And what I mean by evidence is we don't have any clinical trials to tell us what to do here. I usually have a conversation with patients about this, and I think that if patients have had kind of all visible tumor spots removed and have a non-functional tumor, I think it's fine to take a break from a somatostatin analog. If, however, only say the pancreatic tail mass was removed, but they still have a number of liver lesions and we're still trying to control growth of those spots, then it may make sense to continue. So it's very much tailored to patients individually. Also depends if they have a functional or non-functional tumor.
Thank you for that. And someone's wondering if there's any research being done for the oral versus the IM treatment of sandostatin.
Yes, I will claim I don't have a lot of personal experience with this, but there are some clinical trials looking at the oral. I think the question is, these oral agents are going to be like the short-acting octreotide, so they will need to be taken regularly, like daily and multiple times a day. So I think it'll be interesting. We'll be good to get feedback from the patient community on what has better quality of life in terms of frequency of taking medicines versus getting an intramuscular injection once a month. So stay tuned. There are clinical trials looking at this.
Great. Along these lines, can Mycapssa be the first line of medication even before sandostatin?
So I don't even know what Mycapssa is, I will claim, because we all know the generic names.
Yeah, I believe that's oral sandostatin.
Yeah, it's oral. Yeah, I'm like looking it up right now. So let me go back to your question here. It's funny, all of us as physicians, we're all taught to use the generic names. It's not really used a lot in prime time, so I'm going to have to claim I've not personally used it. So I think we don't know yet.
Okay. And do somatostatin analogs cause diarrhea? I know you touched on this a little bit. Would enzyme replacement therapy help, or do somatostatin analogs cause diarrhea secondarily by knocking out the pancreas?
So diarrhea in patients with NETs can often be really complicated. So that's kind of one really important takeaway. And I actually try to talk about this with physicians every time I'm giving medical education talks to other physicians. So I will answer this question directly, but I'll kind of do it just in terms of talking about diarrhea in general. So we as physicians are taught to think about a differential diagnosis of what might be causing a symptom. So diarrhea in patients with NETs is not always carcinoid syndrome. I think that's really important. So it could be carcinoid syndrome if we know, in fact, that someone has an elevated urine 5-HIA. It could also be from pancreatic enzyme deficiency, as we just talked about, and that can either be if you've had part of your pancreas removed, or if you were taking somatostatin analogs that can suppress secretion of the pancreatic digestive enzymes. Also, if patients have had their gallbladder removed, which is very commonly done preventively in patients who are having a surgery for NETs, bile acid malabsorption can occur. So if your gallbladder is not there to hold on to the bile in the GI tract can cause diarrhea. There's medicine to take for that as well, one called ursidile. And patients can also have regular causes of diarrhea, like irritable bowel syndrome and other. So it really requires a thoughtful approach with both your oncologist and often a gastroenterologist and often a dietitian.
Yeah, thank you for that. This question comes up, which is a common one. Can tumors change from slow growing to faster growing after especially multiple years from diagnosis and also being treated with somatostatin analogs?
Yes, this is a good question. And when it does come up a lot, I get asked this a lot by patients directly. So we do know that pace of growth can change over time. And as tumors develop mutations, they can also change grade. And there was actually a very nice study done by colleagues and friends at Memorial Sloan Kettering, Dr. Nitya Raj and Dr. Diane Reedy-Lagunas, looking at serial biopsies over time in patients with NETs. And they, in fact, demonstrated that the Ki-67 and grade and pace of growth can change over time. So it doesn't happen with everybody. And it's something that I think about when the pace doesn't really fit what I know about the prior biopsies or the prior grade. And so occasionally, if that mismatch happens, for example, if the pace of growth is really out of proportion to it being a low grade or grade 1 NET, I may recommend a rebiopsy.
Great. And here's another interesting question as well. Is it ever possible for functional NETs to become non-functional? And I would actually also say vice versa, non-functional to become functional as well. And is there any research being done to stop functional NETs?
So yes to your first two questions. So functional can become non-functional and non-functional can become functional. I think this typically has to do with the volume of tumor. So what I have seen is there are some patients with functional NETs who have cytoreductive surgery or who may have treatment like CAPTEM or liver-directed treatment that significantly shrink the tumor such that the hormone levels decrease significantly. So that can happen. And then I've seen patients who may initially have non-functional tumors develop secretion of one or more hormones over time as their tumors grow. I had just said this, so it's probably worth stating again. Sometimes tumors can secrete more than one hormone, especially pancreatic NETs. And then also, I typically, when I meet a patient with a newly diagnosed NET, check a panel of hormones. Especially, I would say, for pancreatic NETs, but I also do that for small intestine NETs. I will mention there's a difference between tumor markers and hormones. So hormones are something measured in the urine or blood that actually causes a symptom, where tumor markers are often elevated proteins like a CEA is for colon cancer or PSA is for prostate cancer, but don't actually cause symptoms. In our world, that might be something like chromogranin A, but I will say that chromogranin A is really variable. It often fluctuates quite a bit, and I find that it causes more anxiety for all of us than it is helpful.
Thank you for that. So there's several questions about other treatments as well. If you could please comment on CAPTEM, its effectiveness, toxicity, and how appropriate it is for grade 3 midgut NET with liver metastasis.
Yeah. So some of you may know this. So I had the opportunity to lead a clinical trial. It was through that National Clinical Trial Network that I talked about for patients with metastatic pancreatic NETs of CAPTEM versus Temodar alone. And we demonstrated that CAPTEM was more effective than the temozolomide alone, led to a median progression-free survival of close to 2 years, and had a very good shrinkage rate. So that's one of the few medications that actually shrinks pancreatic NETs. And so for patients who have I would say bulky pancreatic NETs or symptoms from their NET, or who may have a kind of slightly higher grade, like a grade 2 or a well-differentiated grade 3 pancreatic NET, I will consider starting with CAPTEM. There is less data for small intestine or midgut NETs and the use of CAPTEM. In fact, I tend to not use it in that indication. I think that it just is not as effective. And what's challenging is that we don't actually have a lot of agents that shrink small intestine or midgut NETs. Lutathera or PRT has about a 20% shrinkage rate for midgut NETs. But we need better treatments that can yield more shrinkage. Occasionally, I'll use IV chemotherapies if I have a patient that we really are trying to get a tumor to shrink, such as Folfox. That's a combination of 5-FU and oxaliplatin. For grade 3, if they are more poorly differentiated, we will typically use carboplatin and etoposide, as I also talked about in the presentation.
I'm glad you brought up Folfox because someone actually mentioned that my PNET, my pancreatic NET, progressed from grade 2 to 3 while I was on CAPTEM. I'm now on Folfox 6 modified. Why is Folfox 6 rarely mentioned as a therapy option?
I just mentioned it. So it's, I think part of it is that Well, first of all, it's used widely in GI cancers. It's really one of the standard of care treatments for colon cancer, for other GI malignancies such as pancreas and gastroesophageal. And actually, Dr. Emily Berksland and myself did a clinical trial years ago now. She did one at UCSF with Folfox and Avastin, which is an IV medicine that blocks blood vessel growth. And when I was at Stanford, I did a clinical trial with capecitabine and oxaliplatin. That's the oral form of 5-FU, also with Avastin. And so together we treated about 80 patients with NETs. And I think it can be effective for patients with neuroendocrine tumors. But it's never been studied in a large randomized clinical trial. It probably never will be, but it is definitely an option. It is listed in the NCCN guidelines as an option. So I certainly have it in my toolbox.
Okay, thank you for that. Speaking of other options, is CAR T applicable to NETs?
We hope so someday. It's not yet and still experimental. But I think that taking advantage, as I'd mentioned, of that somatostatin receptor as the perfect target, I think there are other ways we can think about interrogating that target. And CAR T is potentially one of those. So I think, stay tuned. We've been frustrated as a NET expert community with the ineffectiveness of immunotherapy in general with neuroendocrine tumors. But I think that there are actually other solid tumors that are also not responsive to immunotherapy. So there is a emerging field of trying to figure out how to turn these immune resistant cancers into immune responsive cancers. So hoping that over the next few years, we'll learn more about how to do that.
Mm-hmm. Mm-hmm. Hope so too. Fingers crossed. So this is an interesting question. So after almost 13 years of treatment as a PNET patient, including everolimus, CAPTEM, PRT, lenvatinib, how does a doctor assess cumulative toxicity? So the whole idea of assessing toxicity is interesting.
Yeah, such a good question. And I think really especially pertinent to, all of our NET patients because, we hope our NET patients, even those who are living with metastatic disease can live for many years. And so thinking about this cumulative toxicity is of great importance. That's actually why I brought up that study that looked at the cumulative toxicity of CAPTEM and PRRT. And I'm hopeful that there are new ways we can assess this. I will tell you, I actually just applied for a grant to look at some of these things. And there are actually some ways that we can look at the genetic predictors of side effects. And so I'm really hopeful that we can do this more, especially given that our patients with chronic cancers have often a lifetime accumulation of some of these toxicities. So critical question. We don't have great answers yet.
Mm-hmm. And along those lines, someone asked really great questions. You shared that data, as you mentioned, about treatment-induced MDS. So if you could define that from CAPTEM plus PRT, and can you talk about what's being done for these patients who experience this?
Sure. So maybe I'll just define kind of that baseline. We think from PRRT, at least the data that came out of the Nutter-1 trial, that PRRT alone has a risk of MDS or myelodysplastic syndrome and acute leukemias of about 3%. In CAPTEM, it's the TEM or the temozolomide. That's in a class of chemotherapies called alkylating agents. And the old streptozocin that was used in the kind of 80s, 90s, it's still used in some places today, but not very often. That class of medicines can also contribute to MDS and acute leukemias. And from that study at Moffitt Cancer Center, it appears as if that cumulative risk is about 8%, which is significant. So for patients who develop myelodysplastic syndrome, there are treatments and there are specialists who focus on that. That would not be me or your NET experts. Those are hematologists who specialize in bone cancers. the way we would learn that, we often will see prolonged lowering of blood counts, so red blood cells, white blood cells, platelets. If those are prolonged for months and months and months and don't come up, we often will recommend a bone marrow biopsy as something to assess that, and we can make that diagnosis on the bone marrow biopsy, and then would recommend that you see a hematology specialist who focuses on myelodysplastic syndrome or leukemia. And there are medicines, but it's often tricky to treat. And I think, kind of getting back to the question prior, is there a way that we can predict which patients might be more at risk for developing these conditions, in which case we might choose different therapies?
Great. Thank you for that. That's really helpful. So this kind of goes to treatment decisions. With a low grade, Ki-67 less than 1, non-functional pancreatic NET, would you recommend any treatments to shrink this tumor?
So depends on so many other variables, so it's a little hard to answer, but I'll try to address a few of the comments. So assuming this is a patient with a metastatic pancreatic NET with a low Ki-67, if I'm meeting them in clinic and they're asymptomatic, the tumor burden or volume of tumor is relatively low, I would likely be talking with them about observation or starting a somatostatin analog. And I think this is an important conversation to have with this group. And I think some of you have likely had these conversations with your doctors. And I want to bring up the Clarinet clinical trial, which was lanreotide versus placebo. And it demonstrated a progression-free survival benefit of lanreotide. It was longer than patients getting placebo. But what was really interesting is that the placebo arm had a median progression-free survival of 18 months. So what that means is for patients with these low Ki-67 nets, you have likely had these for years, and I tell my patients that. And I often recommend careful interval imaging. We'd get scans every 3 months and only initiate a somatostatin analog at time that we saw clear evidence of growth. And so it's not wrong to start a somatostatin analog right away, but I think that having that informed conversation, and I will support my patients in really whichever decision they make, but it's also for patients like this, it's okay to delay initiation of therapy because very likely we can spare them being on a treatment for another year and a half. And then maybe one other just last comment on this question. I'll remind everybody, I've mentioned this before, but somatostatin analogs are not going to shrink the cancer. So they will generally stabilize.
Mm-hmm. And how would you approach this differently if it was not metastatic?
So if it was not metastatic, we often will send patients to see a surgeon. And if it's localized, we usually recommend surgically removing it, as that's our best chance of cure.
Okay. Thank you for that. That's helpful. And this person has primary lung now with liver mets. This is actually interesting because perhaps this touched on that lung net trial that you were talking about. What makes someone a candidate for PRT or liver embolization as opposed to proposed CAP-10 plus lanreotide treatments?
Really good question. And I think we don't have clinical trials that give us data on what is the best sequence of treatments. And I think for lung nets right now, the only FDA-approved treatments is everolimus. And so that's why we're doing this clinical trial of PRT versus everolimus. I will say often we can get PRT approved outside of a clinical trial, but I encourage you to think about the clinical trial if you are near an institution that has that offered. Liver embolization includes things like TACE, which is chemoembolization, or bland embolization. For lung nets, we will sometimes consider CAP-10, and we'll sometimes consider lanreotide or octreotide. And all of these patients are in our toolbox for patients with metastatic lung nets. And I tell patients they will likely receive all of these in their lifetime. And how we select the initial treatment or a subsequent treatment really depends on that patient's individual scenario. So is it a liver dominant disease? Is it a functional NET, in which case we need tumor shrinkage? Are they having pain or symptoms from a specific tumor site? So that the actual selection of one of these 4 treatments that are listed in this question is really dependent on that individual patient.
Yeah, that's really helpful. There's definitely not one clear answer, and it's individualized.
Yeah.
Mhm. Um, so, this person asked an interesting question. Do all these new treatments require kidneys to be healthy, particularly if you have bad kidney and high creatinine levels, and this particular person had to stop PRT?
Yeah, really, that's another great question. I'll say it depends. Some of these treatments can safely be done with, higher creatinine levels, which is a reflection of the kidney function, or even sometimes we look at liver function. And so both the liver and the kidneys, and I will also say the bone marrow, are 3 organs that are important to be healthy in order to safely get standard doses of treatments. But some of the medicines can be adjusted and doses lowered in some of these other situations. And I think what's tricky is that in the clinical trials, most patients have to be really healthy. So even though a drug may be FDA approved, it may not really apply to the real world setting where we have some patients with slightly elevated creatinines and other patients with slightly lower blood counts. And we have to use really expert opinion and experience to make some of these judgments.
Thank you for that. So, we don't want to leave out this subset of population. What's new for grade 3 poorly differentiated, particularly upper GI nets? And I just want to comment that we do have an upcoming webinar in March with Dr. Aman Chauhan, who will talk just about the high grade population.
Oh, good. That's great. He just spoke to our Yale team last night. So he is excellent. I'm a big fan of Dr. Chauhan. So well, as I'd mentioned, the good news is that there's a clinical trial now specifically looking at the poorly differentiated extrapulmonary, so outside of the lung, neuroendocrine carcinomas. And I think that, and it was nice to see the abstract also at GI ASCO looking at platinum etoposide versus irinotecan etoposide. And it's important that, we start including some of these patients in clinical trials. They are very different, so they really shouldn't be grouped with the grade 1 and 2. But I am hopeful and really interested to see what immunotherapy does formally when it's kind of tested in the context of a clinical trial in this setting. So I'd say that's our primary clinical trial right now and what we're eager to look at.
Great, thank you. And there's another interesting question here. Are any drugs being studied for non-functioning patients?
So the large majority of patients with NETs are non-functioning, and I'd say most of our drugs for tumor control, are really looked at for both functional and non-functional neuroendocrine tumors. So at present, we're not really separating those out in clinical trials. You may remember that Afinitor or everolimus was studied in a whole series of studies called the RADIANT studies, some of which looked at functional and non-functional neuroendocrine tumors. But for the most part, I would say that drugs that work for tumor control for functional generally work for non-functional.
Yeah, thank you for clarifying that. And as you know, there's been a lot of concern about bone metastasis now that we have better scanning. So how do you treat and slow progression of bone metastasis, especially in pancreatic NET that has gone to grade 3?
Yeah, so I think we're just, because we have this better diagnostic tool, we're seeing bone metastases more commonly in NETs. And I think the incidence of bone mets was likely there before. We just didn't have the diagnostic tool to find it. So in general, when someone is receiving a systemic treatment like a somatostatin analog or PRRT or CAPTEM, that goes throughout the body, including the bones. And so the hope is that it helps control the growth everywhere, including in the bones. I'll make a couple specific comments about bones. However, if a patient has a painful bone spot, we will sometimes use something called external beam radiation. So that's radiation directed like right at the tumor spot, kind of like spot treatment. And that can really help reduce pain. It can also help protect the bone. The other thing we will give, and this depends a little bit on kind of extent of bone metastases, but there are medicines that can help strengthen and protect the bone and reduce the risk of bone fractures. When there are cancer spots in the bones can become weakened and are at higher risk of fracturing or breaking. One of those medicines is called Zometa. Another one of those medicines is called Xgeva. Those are not cancer treatments, but they are bone protectants. And I think those drugs were studied formally in other types of cancers like prostate cancer and breast cancer, have not formally been studied in patients with neuroendocrine tumors. And I think one of the potential side effects of those bone protectant medicines are some really challenging to manage dental issues. And so, and for patients that may have poor dental hygiene going into one of these treatments, that can predispose them to getting something called osteonecrosis. It's basically kind of an inflammation of the bone in the mandible. And so it requires knowledge of your oncologist of this condition, sometimes collaborating with specialists, and then knowing how often to give these medicines. So it's more complicated than we can get into on this, but I think that there are medicines that can help protect the bones.
Yeah, thank you for that. That does come up a lot. And we know you're not a radiologist, but for you, from your standpoint, what do you use as the best imaging techniques to determine treatment?
Yes, it's a great question, and it is something that actually, as the oncologist, we pick the imaging. I'm not a radiologist, but we are the ones that kind of select the imaging. So the main way we monitor patients with NETs over time is either with a CT scan or an MRI. Those are the primary tools. Those are called cross-sectional imaging. It gives us a really good sense of anatomy and size of spots. The CT scan, there's actually a very important way that needs to get ordered for patients with NETs, and it's called a multiphasic or triphasic CT scan. And that refers to how the contrast is pumped through the body. And neuroendocrine tumors are very vascular. And so taking pictures, for example, the CT scan through the liver, when the contrast is in the arterial phase, really enhances and allows us to see the tumors the best. MRIs don't have to be protocoled in a specific way. So those typically, especially for patients with metastatic disease, we get every 3 to 6 months on treatment. I will use a gallium-68 PET scan or a copper-64 PET to answer specific questions that those scans may bring up, or every year or two to help show extent of disease. And I like using the analogy for the PET scans that with using a light bulb analogy. So the PET scans allow us to see the glow of the light bulb, like where in the body is the cancer, but does not allow us to see the size of the light bulb.
Yeah, that's a great metaphor. And there's several questions about scanning and specific scans. So with the new copper-64 available, should I switch from gallium-68 to copper-64? And if I do, does that mean the gallium scans are not reliable baseline for historical review?
So I would say that some institutions are starting to get copper-64, and there are some advantages for the institution for copper-64. It actually has a longer half-life, so it will remain stable for a longer period of time. So they don't have to be quite as precise in how they order it and for which patient. So that's easier. They are generally felt to be pretty equivalent. I would probably say if you're switching, it's fine to switch, but to not go back and forth between the two. It's good to stick with one. And then the other thing is that institutions may be making choices to really only offer one or the other. So it's great to have another option available. And I don't know that it has a huge impact on, they're felt to be both very high quality, and I think it's just really a matter of what the institutional preference is.
Great, thank you. Now, what if a patient has NET on CT, but the copper 64 does not light up? And what's the next step if the biopsies are benign, yet the NET is growing?
So lots of interesting questions embedded in this. So I think that so not all neuroendocrine tumors are bright on copper 64 or gallium 68. It's the minority. It's probably 10 to 15% of NETs are somatostatin receptor negative. So what that generally means is that we would not recommend using somatostatin analogs or PRRT, especially PRRT. I think I don't want to guess, but the use of the word benign in the same sentence as a NET is generally not used anymore. So if it really truly is a neuroendocrine tumor, these are cancers. I think, as Lisa alluded to earlier, these used to be called carcinoid tumors or cancer-like, and in fact, for decades, were not even coded as cancers by cancer registrars. And so there's still some of this like benign malignant in the nomenclature, but if it was at some point proven to be a neuroendocrine tumor, it is a cancer. So I'd say I generally try taking benign out of conversations with NETs.
Yeah. And and your NETS 101 presentation is really what helped me formulate that thinking around it and use that kind of nomenclature. So thank you for that. So, along those lines again, with the dotatate scanning, can a NET tumor in the prostate be diagnosed with ultrasound? And does uptake on a dotatate in the prostate indicate NET activity there, or is it incidental?
Good question. And I think so. So a NET tumor in the prostate, I think we can sometimes see that on ultrasound, but really the gold standard, there has to be a biopsy to prove a neuroendocrine tumor. We can see dotatate avidity in the prostate that is kind of a true positive, indicating that it is indeed there. There can also be some false positives, meaning that there's just physiologic uptake. There are actually a number of places in the body now that we've had these DOTA-PETs available for many years. So the pituitary gland shows normal physiologic uptake. The spleen shows normal physiologic uptake, as does the liver. There's some normal bowel activity, and then we see on the scans the kidneys and the bladder look bright because that's how the contrast material, the gallium peptide, is excreted in the body, is through the urinary system. So I think it's helpful to have a really experienced nuclear medicine physician reading these scans because they will be able to tell you what's positive and what's physiologic.
Thank you for that. Now, of course, there's questions about foods, and are there any food that NET patients should avoid completely? Do you know of any nutrition specialists, nutritionists, dietitians who specialize in working, especially with Whipple patients or NET patients in treatment?
So I think that varies, and I'll go back to one of the important ways that we think about patients with NETs is that functional or non-functional. In particular, patients with carcinoid syndrome may have food triggers. They are not kind of absolute contraindications in terms of eating, but they might have serotonin-containing foods that might lead them to have flushing episodes or more diarrhea. Those includes things like avocados, nuts, tomatoes, and there are available lists of these types of foods. And again, it doesn't mean you can't have them. It just means they may make you feel yucky. And so it's just listening to your body and knowing which of these foods may contain serotonins and amines. I would say in general, as a kind of cancer healthy diet, we recommend a heart healthy diet or a Mediterranean diet, diets that contain high fiber and low fat. There's no magic other than that, and especially for patients with non-functional NETs, there's no magic diet. I would say, especially though, after bowel surgery or a Whipple, there may be some special dietary needs. And so, partnering with a dietitian who does have some experience in GI cancers or in gastroenterology is really important. And I think more and more institutions are having dietitians that do have some disease area expertise.
Thank you for that. And I know that we're coming to a close. There were several questions about PRT that we won't have a chance to get to, but Dr. Eric Mitra is going to join us in April so he can get to all the imaging questions and PRT questions. So we'll just end with this. What are you most hopeful for in 2022? And you can answer that however you like.
That we're done with COVID. So besides that, so I love this field. I always look forward to talking to patient groups. I wish I could be with you in person. And I'm in this field because I have seen this trajectory of advances over the last 10 to 15 years that has just been exciting. And I think this was a field previously that had been neglected. And there are some really dedicated neuroendocrine tumor physicians, physician scientists. And I think I'm actually most excited right now about all of the young investigators that we're recruiting into the field. I think that the future of the field is really bright because of that. And I think investing in junior investigators and junior faculty is incredibly rewarding to me, and I think will really make a huge difference to the field moving forward.
Thank you for that. Thank you for your terrific presentations, for your presence, your energy, your dedication to the field of NET. We couldn't do this without you, and we're very grateful for all you do.
You are welcome. It is my pleasure to be a friend of LACNETS.
We're so grateful for you. And with that, I'm going to send it back to Rich in the studio. Thank you again, Dr. Kunz, for your educational and hopeful talk. Be sure you're following LACNETS on social media, Facebook, Twitter, and Instagram to stay up to date on upcoming webinars and NET news. And we'd like to remind our viewers that these webinars are done for educational purposes only and do not substitute for medical advice. We encourage you to talk to your medical team if you have any questions or concerns about your individual care or treatment. We offer many programs and resources, including our weekly NET support group, a dedicated caregiver-only support group, NET Vitals, which is a downloadable patient-physician communication tool to help you prepare for your medical appointments, and health coaching, which is available to NET patients or caregivers. We encourage you to go to our website, lacnets.org, to find out more information about our programs, view resources, read blogs, take NET quizzes, and much, much more. LACNETS recently launched our new podcast featuring local NET experts who answer the top 10 questions in their field. We hope you'll take a listen. We've been releasing one episode every month, so stay tuned for more. Thanks again to our special guest for today, Dr. Pamela Kunz. We are grateful to you for all you do for the NET cancer community and for your dedication and advocacy and support. Thank you to Rich at TVP Live and for all of you for joining us today. Goodbye and see you next month.